I was just gonna say, rock and roll.
Am I up first?
Yes, follow the run of show.
Yeah, I can't find it. I had it open a moment ago. I think I'm up next. Alexa, could you pop up the presentation?
Yes.
Will you be controlling it today, or will whoever's speaking be controlling it?
I will be controlling it.
All right, let's go.
Maybe. Let me.
All right, let's begin. My name is Jeff Riddell. Good morning. I'm a faculty member in the Department of Occupational Therapy Education, and I serve as the Associate Dean for Academic and Student Affairs in the School of Health Professions. Well, I'm not a healthcare provider myself. I do have a keen interest in how society can move beyond just a simple awareness of differences and actually to gain better understanding and appreciation of the needs and the goals for all people in our community. Academia, however, often is, well, too academic, and teaching about and researching the issues sometimes just doesn't cut it. Our organizers today believe that the symposium speakers and the discussion that they're likely to generate will help move us to a greater understanding of disability needs and expectations in relation to the provision and the receipt of healthcare services. So we have a few opening elements. Zoom etiquette, mute when you're not speaking. Be mindful of your background when your camera is on. There are a few thanks that I think are important. The information is listed on the screen of who our programming committees is, and I think that it is appropriate to say thank you twice, because in fact the same committee helped develop the symposium last March, which was then canceled because of the pandemic. So they came back for round 2, and that deserves a special thanks. We're supported and sponsored for this event by our area health education centers, the EVC's Diversity and Inclusion Cabinet, the Office of Continuing Education, and the Office of International Programs. And I especially would like to thank our TLT staff, without whom a virtual event will be impossible. Thanks for supporting us in the background there. Some other notes, the handouts, both the symposium PowerPoint and the symposium booklet are available on the Office of International Programs website. There's a link in your materials. The symposium PowerPoint was designed with ADA accessibility guidelines. We'd like to encourage our audience to consider using those same accessibility guidelines in your own materials as you move forward. We have 2 sign language interpreters today, Sarah Kurtz and Mindy Johnson. If you are willing or interested, you may pin their interpreter's screen video to the top of your screen so they're constantly visible. There is continuing education credit available for this session. There are a series of slides coming up in just a moment when Alexa pushes the magic button that provide information for physicians, nurses, social workers who may be participating with continuing education in mind. We'll flash this information up regularly throughout the day, so you don't have to keep this in mind. There are, in fact, a rule about conflict of interest, and as far as I know, none of our presenters have declared a conflict of interest. Next slide. And I'll pause here for a moment so you can get out your phone or screenshot this particular image. This slide will take you to, will provide the information for signing in for continuing ed. As the day progresses, use the chat box to submit questions or comments. It will be moderated and monitored, and we'll sort those as they go. We'll save the chat and distribute it after the symposium. We do have a Q&A session at the end of the day, so if your question is not answered as soon as you ask it, there's a good chance it'll crop up again at about 2:30. Please join us at that time. We have an open invitation to any of our presenters to circle back if they're not sticking out throughout the entire symposium, to circle back and participate in the Q&A session. We do have a website for the symposium. It has a ton of information on it. You're welcome to navigate there. It will be available going into the future. And at the end of each session and at the end of the day, we will have assessments that will allow us to have a better understanding of how we've done today, but also prepare us for providing similar presentations in the future. So your answers and information from those surveys will be appreciated. All right, next slide. So one of the problems with having really competent people is they have really long biographies. So, and every time I read one of these out loud, I go away feeling less competent than I'd like. So I'm going to leave it up to you to read this document and appreciate Dr. McGee's accomplishments. And I just want to say that these accolades and accomplishments, they're really impressive, but I'll also vouch for her approachability, openness, and deep insight about the essential need for diversity, equity, and inclusion in society generally, as well as how to apply these principles in the operation of an academic medical center. Her leadership in this area has been unparalleled since stepping into her present role as Vice Chancellor for Diversity, Equity, and Inclusion. But I'll tell you now, she's been doing this all her life. So please join me in welcoming Dr. McGee, who will do the opening statement.
Thank you, Jeff. I truly appreciate the warm welcome that you have just provided for me. And I agree that, you know, every time I read someone's, I feel the same way, but you know what? We all have our lane. And it's, you have done things that I will never do, Jeff. You have received grants and all types of things. So I think we all have our areas of expertise. And so we just value one another and what we bring to the table. So as Jeff stated, I am Geraldine, and I am here to provide the welcome for all of you. So I'll provide you with a little bit of history. During the summer 5 years ago, then Executive Vice Chancellor, Dr. Doug Girard, who is now the Chancellor for the University of Kansas, had a vision for Diversity and Inclusion Cabinet's Programming Committee. He saw a need for issues related to culture and diversity to be connected to the clinical care and research. At that time, the Tilford Conference on Diversity and Multiculturalism was offered and supported by Regent Schools, but its undergraduate traditional campus focus lacked in material directly related to the medical center, which we can kind of understand. So Dr. Girard had a vision for a conference or symposium that would be relevant for healthcare providers, educators, and researchers here at KU Medical Center, as well as our neighbors who partner in delivering healthcare in Missouri and Kansas. So the symposium was born the very next spring in 2017. The first symposium focused on refugees in the healthcare system, followed by our second with a focus on palliative and pain across cultures. Our third featured health literacy, and our fourth symposium today focuses on disabilities. Each year, the programming committee asks KU Medical Center faculty who have expertise in the topic to lead the symposium team. The first year, Dr. Martha Baird and Joseph Lemaster formed the content of the symposium. The second year, Dr. Christian Sinclair was the lead for the palliative care. And the third year, Dr. Crystal Lumpkins was the faculty lead for health literacy. And this year, Dr. Jeff Rodell has led the content for the symposium this year. We want to express our gratitude for their expertise and their guidance. And I truly mean that for all of them, because we need experts in areas and we all can't know everything. And so it's so important for all of us to bring our skills, expertise, and our knowledge to the table so that we can make KUMC great. I personally want to extend a warm, heartfelt welcome to all participants from our Kansas City, Salina, Wichita, and Lawrence campuses, as well as our partners from the health system and Children's Mercy and beyond. Today, we have the opportunity to be enlightened by some of the best around a very important topic, disabilities. I am confident we will all use this information to advance health and foster a more inclusive learning, working, and healthcare environments. So thank you very much. Alrighty, so I will go ahead and introduce Natalie Hollick is the director for the Office of Compliance at the University of Kansas Medical Center, where she is responsible for compliance program oversight, which she is really good at, policy management and training, which she is really good at, and oversees various compliance programs that target high priority risk areas such as Title IX, privacy, conflict of interest, and research misconduct. Natalie Hollick.
Thank you, Geraldine. Good morning, everyone. I'm still trying to get used to talking into a computer. You know, I know we all wish we could be in person today and be together. But I also realize, you know, I know for me and probably for many of you over the last few months, I've learned how valuable technology is. And for many people, technology is that bridge to communication and participation in a way that many of us may not have realized or thought about before. And so I'm so grateful that we have the technology and that we are able to be together today in this way. So I have been asked this morning to speak on some of the efforts that the University of Kansas Medical Center has made towards disability inclusion, and particularly a disability survey that we put out recently. But before I talk about these efforts, I did want to touch generally on the why behind this. You know, why do we care about disability inclusion? Why is that important? And I think for most, if not all of you, you know, participating and listening in today, you know those reasons. You know, we recognize that the inclusion of all individuals of all abilities inspires innovation. It helps us instill greater diversity in our collaborative efforts. It provides for a greater talent among those we work with so that we have more opportunities and experiences and ideas to pull from. And simply because it's the right thing to do. We want everyone to be included and to feel that they can be engaged and participate. So with that, you know, we recognize the University of Kansas Medical Center's commitment to diversity and inclusion. And we have brought along this journey from, as Dr. McGee spoke of 5 years ago to now. And so I want to talk briefly about that journey, that background that leads us to the survey. So as Dr. McGee mentioned, in 2015, Dr. Gerard had this vision of forming a cabinet and got a committee together, and the cabinet was formed. Soon after that, there was an idea of recognizing, you know, we need to see where we are, you know, before we can kind of move forward in our efforts to build a culture here of diversity. We need to see where we are. So we conducted a climate survey in conjunction with Lawrence. That climate survey gave a lot of feedback, a lot of information to us. You know, we asked a lot of the usual questions, you know, do you feel comfortable in your environment? Do you feel comfortable here on campus? Do you feel that you are included? Do you not feel? Do you feel supported? And as you know, we expected, we got a lot of positive. You know, yes, I feel comfortable here. I feel included, which was great. But there was also very noticeable marginalized groups that did not feel that way, and one of which was individuals with disabilities. And some of the things in the survey that they brought out, that they pointed out, were that they felt there were lots of barriers. Obviously, it's easier in many respects to point out physical barriers, and that's what a lot of the focus was on. A lot of the comments recognized that parking was an issue. Sometimes we had, people having to park from several parking lots away to get onto campus. Some of our walkways and paths are not clear. For those of you who are not familiar with our campus, if you look at it from, an aerial view, it looks like multiple buildings. But inside, all those buildings that have been built in different periods of time have all been kind of opened up inside. So it's like one giant, building from the inside. You don't realize you're walking from one building to the next, but there may be differences in the flooring, differences in the what's been upgraded or renovated because of the age of the buildings. And so there are some facility barriers that we've been addressing. So those were pointed out, as well as different communication barriers and such. So some of the other, one thing that also I thought was interesting is although many of the barriers that were pointed out in this survey were addressing, people with physical disabilities, the majority of those in the survey who identified as individuals with disabilities had non-visible disabilities. They indicated they had diagnoses of such things as anxiety, ADHD, chronic conditions like asthma and diabetes. So in taking a look at that survey and really recognizing that there's more that we can be doing for this particular group, in 2018, I put a presentation together to the Diversity and Inclusion Cabinet and kind of brought these up and asked the cabinet, they were doing great things focusing on a lot of different areas, like we had the symposium going, but there had not been a specific effort towards individuals with disabilities and how we can really include them. And so we brought that forward to the cabinet, and of course the cabinet was receptive, so we want to do something. So in 2019, we formed a subcommittee focused on disability outreach. And the first effort of that subcommittee was to, again, conduct a survey, find out, what is our population, what are the needs, and what can we do? Next slide. And I wanted to say the things are pop up. So in that 2018 presentation, I went back and looked at it to kind of get some, to see where we had been. And I just had to smile when I saw what came up here. These at the time were suggestions. And if you can go ahead and bring those up, there should be pop-ups here, yeah. So one of them was to make accessibility a priority. And, I think probably with a little push from COVID, we have moved so far in that way in making our technology more accessible, in having sign language interpreters and having captioning, and in understanding more about how we can be more inclusive and provide more accessibility in our technology. So that is something that we had recommended that is now coming to fruition. The next one, supporting creativity and accommodations. That is also something that I was excited when I read this to think of all the things we have done. There are many creative ways that we have come together, collaborated with different departments and groups when we've had either a student or employee request an accommodation. The response has been, how can we make this work? What can we do? What can we think of to make this a success? Rather than, how can we say this isn't going to work because it's too difficult? And so that has been really exciting. One more. Hosting programs and guest speakers. Look where we are today. I was so excited when I saw this. I thought, wow, look, this is something that we had recommended 2 years ago, and here we are, an entire symposium focused on disability outreach and inclusion. And I was just excited to see that we are making strides. And then finally, I think encouraging recruiting efforts, and that's something that we're always working towards and continuing to improve. So I just thought that I wanted to share that because I thought that was exciting when I looked back to see what we were hoping to move towards is some of those are coming to fruition and even continuing to improve. Next slide. So getting to the survey, that's what I'm supposed to talk about. We had 341 people respond to the survey. Not a huge number, but we were pleased with that considering we did not do significant campaigning. We were trying to get this out as quickly as possible to start action items and start moving on it. But of those who responded, the large majority indicated they did not have a disability or did not identify as having a disability. Of those who did identify as having a disability, the large majority indicated it was a non-visible disability. And the large majority of the respondents were employees, although there were a few students who responded, and it was open to the entire campus. Next slide. So demographics, race and ethnicity, the large majority were white. The next largest was no answer, and then Asian. And for gender, the largest majority by far was the cisgender female, followed by cisgender male, just to give you a kind of a makeup of our participants. Next slide. So one of the things we wanted to capture was what was the knowledge of people taking this. You know, if they needed to seek an accommodation, did they know where to go? And this is really eye-opening because the majority said they did not know for either employees or students. So again, that helps us recognize we need to bring that awareness. I will say right now for all of you, if you are an employee and you need an accommodation, you should seek Cherry Young in Human Resources Office. And if you are a student, you should reach Cynthia Yokoko in Student Services. Those are the people who handle accommodations for employees or students. So we can continue to educate on that and help improve that status. Next one. We also asked if people were aware of physical barriers or impediments and what did they see on campus. The large majority said no, and I'm thinking that is probably in correlation to the large majority of people not having, not identifying as having a disability and may not being as aware or as conscious. And I will point out there was a comment made in response to the survey that I thought was really interesting, that somebody indicated they did not have a disability or did not identify as having one, but this survey really made them think about things they had not thought of before and looking at the physical setting around them and kind of recognizing that things might not be as easy for some as it is for them. And I thought that was great just to see that the survey was having some educational and knowledge, helping people recognize that as well beyond just taking the survey. Another was how satisfied are you with the efforts to make the campus accessible? And most people said somewhat satisfied. There were some very satisfied and a few not satisfied. So we were pleased with this in a sense, but we also recognize there's work to do. Some of the efforts that were recognized that we have done, there were many that had noted the renovations to the Murphy entrance. Again, if you're not familiar with our campus, our front entrance for a long time had many, many stairs. We've now almost completed a beautiful renovation that has a wide ramp circling and nice landscaping. They were recognizing that other new ramps in the areas, some acknowledged the survey and the fact that we're focusing on this. Thought that was a great effort and appreciated that. There was also quite a bit of recognition for Dr. McGee's new role, recognizing that the medical center is placing importance on diversity overall by creating the vice chancellor role and moving forward in that area. Next slide. And so we also asked what are some things that can be done that they would like to see improved. And there were lots and lots of ideas, which we really appreciated. A few of the ones that stood out the most were, there was a lot on improving signage and improving directions. Again, our campus is kind of sprawling, and if you're not familiar, you can go all the way from the health system through our entire schools, and it's easy to get lost if you're not familiar. So thinking about somebody who may need to get from one end of the campus to the other and know not only how to get from A to B, but how to get there in an accessible way. Where are the ramps? Where are the elevators? How can they get there without having to backtrack? So that is something that we recognize we really want to work on. Just greater education around accommodations were a couple of comments. allowing for flexible schedules, which I think, again, kind of a light, a light in dealing with COVID is recognition of telework and the ability of people to work from home, and how successful I think that has been. And people have demonstrated that they can still be productive working from home. So I think that's something that we will probably see continuing, and even make that more available as an accommodation. Some updates to restrooms. There was a lot of comments regarding difficulty in maneuvering in through the door. Often the trash cans get moved to the doorway so that people can throw their paper towels out as they walk out. Sometimes the changing table is in the accessibility stall, and so that makes it difficult if somebody is using it for that purpose to use it. So just a lot of ideas and mostly facilities type barriers and opportunities that we have to focus on improvements. Next, please. So in taking all of these ideas in the survey, the committee pulled together what could we focus on first. And we tried to, we wanted to be sensitive to the needs in the survey, and we also wanted to look broadly at, what can we do for the whole campus. So one thing we are working on now that we would like to post soon is developing a website of resources. Just having some single source where people can find where they need to go for accommodation questions, for if they see something that's, if an elevator isn't working, or if there's some facility, some physical barrier, physical problem that they can report it, things like that. So we're working on that. We also want to identify a resource to kind of catalog all those issues that are happening on campus, because we can't always know when an automatic door has stopped working unless somebody tells us or we're checking that. And then again, in regards to the mapping or the signage, we looked into the health system is currently piloting an app called My Way Navigation that is it's like a GPS controlled from inside. And so it can tell you where to get around within the buildings. And so if they are successful in that pilot, we are going to see about adding that to the university side so that people can download an app that can help tell them where the accessibility features are, where, where's the elevator, where's the ramp, how do you get from A to B, which we think would be a great benefit to have that, not only for people who need elevators, but just anyone who needs to find their way around. And we, this is something we were wanting to work with IR and communications to develop a policy to improve the accessibility of video conferencing. And I think, again, thanks to COVID, I don't want to say thanks to COVID too many times, but you know what I mean? I think that has helped us move a long way in that regard, that we've really advanced our accessibility standards for video conferencing. And then finally, beyond the survey, we really want to focus on identifying opportunities that will more intentionally engage persons of all abilities, because we recognize the value in diverse perspectives and the experiences. And I think one way we are doing that is today with this symposium. So we are really pleased with the start here, with what the feedback we received from the survey, the action steps we're taking, and we're excited to have the support of the Diversity and Inclusion Cabinet to keep moving towards further goals and further inclusion efforts. So with that, are there any questions? Are we taking questions? I'm happy to do so. Thank you, Jeff, for putting in the chat. Are the Cherry Young and Sinew Coco are the persons to contact for accommodations? I don't see any questions. Okay, well then I am delighted to introduce the next group of panelists. The consumer panel is going to be moderated by Jeff Riddell, PhD. He's an associate professor in the Department of Occupational Therapy and Education at the University of Kansas School of Health Professions. The panelists will include Mickey Keck, who is an instructor and advocate for the whole person, Brad Lindenkamp, who is a community liaison for the Kansas University Center on Developmental Disabilities, Stephanie Coleman, is a family support coordinator for the Center for Child Health and Development at the University of Kansas Medical Center. Christopher D. Johnson is an instructor with the Department of Education at the University of Minnesota Duluth College of Education and Human Service Professions. And Stephanie West Potter is a disability consultant at Stephanie West Potter Consulting. So welcome to the panel.
All right, well, I'll take over then. This is Jeff. I think the sort of where we are in the thinking about the symposium is we've taken a good look back at what we're doing as a campus and in that healthcare environment. Seems sensible to just ask people out there in the real world what is their experience and what can they tell us about how we're doing and things that we could do better or more efficiently or more effectively. So that's the essential purpose of having this next group of people present their background, their insights, and their suggestions. They're an eclectic group of people that were recommended to us by our extended network of both community and academic types. I don't actually know what they're going to say because we gave them guidance saying what's important to you. So I think that's probably a good place to start. My recommendation, I think, is that we're going to spin through each of the panelists, letting them give a brief statement and then come back for a larger discussion. This portion of the day is will extend to about 9:20. Please add your questions to the chat. We'll try to put them forward to the panelists. And if the question's for a specific panelist, add the name. And if it's for the group, just let us know that it's a general question for the entire panel. Mickey, could you speak first, please?
Oh, hold on one second. I can't see her. I can't see you. Hello. Can you see me?
Alexa, I think if you could stop sharing the screen, because at this point, I think we need to see the people.
Oh, hold on. She disappeared. Oh. Okay. Hi. Hi, my name is Nikki Peck, and I work here at The Whole Person as a deaf advocate and also an ASL instructor. I guide different workshops and trainings, and you know, I can speak from my experience at The Whole Person and also my personal experience as a consumer also. I work with a lot of deaf refugees here in the Kansas City area, and I know a lot of them do go to KU. So there is just, there'll be a much more diverse discussion later.
Right, is that it? That sounded like a period.
Yep.
All right.
Yep. Yeah, I'll save the rest for later.
All right. I looked through the names of everyone who's here. I'm not sure our next panelist is in session at this point. If Brad Linnenkamp is available, Brad, can you connect up and say hi? Perhaps he's not available. We'll move on to the next panelist, Stephanie Coleman.
Good morning. Excuse me. I am Stephanie Coleman, and as mentioned, I'm the Family Support Coordinator in the Division of Developmental and Behavioral Sciences at KU Pediatrics, and also the Family Discipline Mentor in the Kansas Leadership Education in Neurodevelopmental and Related Disabilities. Acronym is LEND. Here at the university. I assist families navigate their new world after an autism diagnosis. I am also the mom to Matthew John, who is 25 and on the autism spectrum. And Matthew is currently a junior at the University of the Ozarks working towards a bachelor's degree in communication. He hopes to one day be a camera for his beloved Kansas City Royals.
Alexa, can you pop up that image, please? Oh, there he is.
Yes, there's Matthew. He's hit some milestones where he's gotten his driver's license at the age of 23. He's a athlete for Blue Valley Blue Streak Special Olympics when he is at home. And up in the left-hand corner, I'm very proud, he's wearing his mask on campus as requested and required. So he is a typical kid, makes me proud every day. And he's also a voter, a very proud voter. He's been voting with his mom since he was 2 out of need of necessity. And the first time he got to vote in the presidential election was 2016, and they made a fabulous experience for him there. Everybody celebrated his first election.
So Stephanie, you've got a question in the chat. What's his sport?
What is his sport? Well, we start at the beginning of the year, there's basketball. He does, what is after basketball? It's been a while. He's also done golf, soccer, softball, and I know I'm missing some, tennis. And then his not so favorite track and field. Running is not his favorite thing, but it makes his mom happy that he gets a little bit more opportunity to exercise.
All right, well, thank you for that introduction. Alexa, let's go back to the speaker view. And next up is Christopher Johnson.
Thank you, Jeff. Wardell, thank you. Well, I just want to welcome everyone, students, staff, and really thank you for allowing this place and time. My name is Chris Johnson. I went to Gallaudet University for interpreter education, and really I work at the Deaf Institute. I also work in the state at the government, and now I'm an instructor. So we're just trying to figure out, how we can figure out a way to work together to kind of connect both communities, the hearing community and the deaf community. My hope really for this, for today, is really to reduce, any misconceptions or misunderstandings that we have between the deaf and hard of hearing and hearing communities. So thank you.
Great, thank you, Chris. And Stephanie West Potter is our final panelist.
Hi, I'm Stephanie, and I am a disability consultant focused a lot on mental health in the workplace. I am also a person with bipolar disorder. I was diagnosed when I was 19. I honestly have not been able to do much consulting because I'm also a parent of 4- and 5-year-old boys, both with disabilities. So I'm trying to navigate online preschool and kindergarten right now. So just a warning, if I have a kindergartner walk in while I'm speaking, I apologize. I can't control what's happening out there right now.
Well, thank you. Good luck. We've met our panelists. Our chat window is open for questions. And Kimberly asks a general question for all panelists. What has been the greatest success in this area of understanding and awareness around disabilities?
This is Stephanie, and I'll say, I think that from an autism perspective, is that we're seeing more and more diagnosis, individuals being diagnosed, so more and more awareness is coming out there, and we're also starting to see acceptance, and that's hugely important, especially to me as a mom, that individuals with autism are accepted for their strengths, always looking at their strengths. Yeah.
And you're saying that after years of experience rather than someone with a child with a new diagnosis.
Yeah, definitely it was a long road. When Matthew was 2.5, he was diagnosed with ADHD, and not being educated from a clinical standpoint, I always assumed all of his quirks or things that he did or didn't do was because of the ADHD, and then his autism wasn't diagnosed until he was 13. So it's been a long road. Been an interesting one, but he's been a great guide.
Thank you. Let me take a break because it looks as if Brad has just joined us.
Yes, I have.
And so Brad, we're partway through the panelists. We've just done a brief introduction of each one and passed you over. So can you tell us a little bit about yourself, couple of sentences, and then we'll get back to questions and answers.
Yeah, my name is Brad Camp, and I work as the community liaison at the University of Kansas and at the KUCDD. And my background has been mostly, before I came to KU, was in disability advocacy, and been doing that for over 20 years. So I have a lot of different experiences that I could bring to not only KU, but in other areas of the community where people with disability want to be a part of the community.
Well, thank you very much, Brad. We're in the midst of answering a question for each of anyone who wants to answer it. What's been the greatest area of success in understanding and awareness around disability? Stephanie has just said the acceptance and awareness and acceptance of autism has been a major step forward. Anyone else who wants to take a stab at the answer? Stephanie?
Yeah, I would agree with the same thing when it comes to mental illness. You know, for the first time, I think in the longest, well, definitely as long as I've been diagnosed, I was first diagnosed with depression when I was 12 after my first suicide attempt. And I think so many times about what it would have been like to have the awareness that is going on now whenever I was that age. You know, I didn't see any celebrities talking about that. Whenever I went to the doctor, there was no screening asking me how I felt, how my mood was. So I think that is a really huge step forward that we've made. The stigma is still definitely there, but just asking those questions and making it a comfortable environment to discuss mental health is a huge, huge step forward that we've made, I definitely think.
I know that the patient intake and the patient forms, those things you have to fill out every time you go to the doctor, have changed quite a bit over the past decade. And certainly within the past few years at KU, they've really recreated some of those forms. We have a couple more questions, but if anyone else wants to weigh in on
Yeah,
this
I have something.
question.
This is Christopher.
Sure. Go ahead.
This is Chris, and my most successes be that the expectations plus the actions plus the solutions for equality and inclusion. You know, if the mayor is currently progressive, you know, and not doing things in a later date, my experience would be, you know, that, you know, going to different states and seeing what's going on. And my individual experience is first accessibility going into the hospital and thinking about what the people said or what the nurses and doctors were saying, and have to think about, is it the, you know, before they make those diagnoses and doing those studies, and seeing that I've seen an awesome improvement of inclusion. And for, you know, people not saying hearing impaired anymore, they're saying deaf and hard of hearing. They're using the right communication, the right diagnoses. For example, for blood pressure, you know, it's fine, but my anxiety didn't show. And so, knock on wood, I haven't had this happen to me, but I've seen it happen to other people. Their blood pressure was really high and they were given blood pressure medication, but really it was related to anxiety. And so, they didn't have access to an interpreter and they might have been fighting for accessibility. And before their appointment, they have to really fight to get that. And so I've seen the hospitals and doctors more willing to work and communicate with the community, you know, the intercultural communications and the partnerships. For example, in Kansas Commission for the Deaf and Hard of Hearing is partnering and asking, what's available out there and what resources that they have, and partnering and doing training with their staff and others, and making more awareness for the deaf people now, so they're not having to fight as much and be so exhausted about it. So I've seen that huge improvement. And this is Mickey. And I agree with what Chris has said, and focusing on the positives, and the more awareness. And more specifically, still, there's some struggles with communication. I feel like I'm lucky that I work with children in Mercy Hospital often, and I go there for the deaf awareness training with the nurses and social workers and, just in general. But who is the deaf community, and teaching them who they are and what kind of deaf people are out there, and culturally what their culture is, and maybe they're from a hearing family or the person is hard of hearing. Some people, have hearing loss that is continual. There's just so many, or they were late deafened, so they, maybe they're not able to speak, maybe they prefer to sign. And so the person who is oral or hard of hearing, so people might assume that everyone is the same way because they don't sign. And so having the confidence to use sign language or captioning, people like the captioning. Some people prefer the interpreter. So there's just a variety of cultural differences, and always polite. You need to be always polite and ask to communicate with them, and offering the services and the choices for them. So I just think that, and that's just in general, I've noticed more and more awareness now of those options.
I actually have a question for the two interpreters. So, sorry to put you on the spot. How have you seen the interpreter?
The interpreters have to follow their code of ethics.
Okay,
they're not able to jump out of their role today. So, but I could discuss or expand about interpreters if you'd like to ask me, or Chris can.
If you're open to that, my question, because we do have, at least in my school, the hearing and speech department, ASL training, and I understand that ASL training is not the same as training in a medical environment.
No. Hold on just a second. I can't see Chris.
Okay.
1 second. I'm not sure what the right word is for it, but it depends on what environment they're in, if it's related to court or medical or hospitals or education. There's a variety of different, needs. So it really depends on, what you're asking.
My principal point was for our audience to recognize that a regular signer may not be an appropriate person for a medical environment.
That's right. This is Mickey. That's right. Because in a medical environment, you have to have higher skill level. And so the interpreter must have their certification, because if they, make an error or a misunderstanding, it could be life-threatening. And so I've heard many stories about this, and interpreters must follow the role and they cannot step out or offer personal information or personal advice or opinions. They have to follow strictly.
Agreed. Thank you very much for that segue. There are a couple more questions. Oh boy, a bunch of more questions.
Chris had something else.
Oh, go ahead. Go ahead.
I just wanted to add one more thing that's really important is to ask, not to ask the family members to interpret for any patient ever. You know, it's a violation, and you know, and they can be sued in the future if that happens. So it's just really important. The family members understand how to communicate with them, and you know, maybe, but they're not able to translate the information. So if they have their certification in medical, or the interpreter needs to have it or not, you know, so you got to make sure that the interpreter is certified with that medical.
Right, and this is a larger than just signing interpreters. This is interpreters for language as well. Any interpreter, it's important to have
Right.
the formal interpreter, not the informal family member.
Right.
All right. Could the panelists speak to how COVID-19 has impacted you personally or professionally?
This is Mickey. Yes, it has impacted me personally. You know, with the masks, it's been a huge challenge with the facial expressions. For the example, in January, February, somewhere in there, I was having had an ankle injury, and I went to get it checked out, and I expected to see an interpreter, but they brought in the video relay interpreting, the VRI, which was fine. So, but the VRI was broken, and so they said the IT would come, and I was in so much pain. I was sitting and sitting and sitting, and I told them, I said, call the interpreter to come. They'll be here quickly. They're saying, no, we're going to fix the VRI machine. So I waited 2 or 3 hours, almost in the 4th hour. It was noon at that time. They called an interpreter to show up, and they showed up in 15 minutes. And so I was like, okay. So, and then I got an appointment with the bone specialist, and then COVID hit, and the appointments got canceled so many times and put off. And finally I got to see the doctor, you know, taking myself in there. But then we had the mask and the social distancing, and the interpreter didn't show up. So I'm like, okay, I felt like, you know, it was a no-win situation for me. So then later they scheduled the interpreter, and I was stuck with this for 4 months. You know, the mask are really awkward, and it's just in general information. That just gives you an idea of some of that personally.
This is Stephanie Coleman, and professionally, I've been blessed to be able to work from home, so it really hasn't affected me too much. But personally, I think the hardest thing was, one, helping Matthew understand why we were quarantined and he wasn't able to be at school. And then also, just last month, it scared me to death to send him back to school. You know, he's been really good about wearing the mask, so I knew he would follow those rules. It's a smaller university, but he does have additional, like, asthma and some other things that really concerned me. But I had to take in the thoughts that was the better learning environment for him. So I just put my trust and faith and sent him on, and still worried. And obviously, until this is over, I'm going to be worried. But
Thank you.
This is Stephanie West Potter, and I, other than the fact that I became a stay-at-home mom of 4 and 5-year-olds with autism, and had to put my career on hold for that. I do want to say one of the biggest positives that have come from this is that I'm now able to access telemedicine that I was not able to do before. I am able to still see my therapist weekly while my kids are here. I don't have to go to the office, and that has made such a huge difference. And I think it's opened up the door to using telemedicine in so many other areas. You know, it helps with people that have anxiety that aren't able to get out of their home, or transportation issues. You know, there's so many things that telemedicine has now shown that it is effective, and something that should continue for sure after COVID. We've really proven that it works.
That also helps when somebody's out of state and needs to see his psychologist on a regular basis. So I am ecstatic about that as well.
This is Christopher.
Hang on, Brad, we'll get to you in a second. Go ahead, Christopher.
Often I advocate for others who don't have a voice or able to express themselves or feel oppressed. And they talk about the mask. And for those of you, you know, thinking about, related to actions, I mean, ASL itself is grammar found, all of its grammar is found on the facial expressions and its body language, and the deaf, you know, are able to understand that. But with the mask, it is a huge barrier for that. And that's why often hearing, think mask, you know, they think about their ears, and our ears are our eyes. And so, for example, our mouth and the facial expressions, for us to be able to understand and consider think about looking at other perspectives and other ways to buy more accessible mask, and partner with other organizations and state commissions and asking them, you know, what their needs are throughout their state. So that's it.
That's a really good point, Chris. We had this experience at our institution where we have, of course, spent a lot of time looking at what are the right masks, how to, you know, who needs them, and, you know, all the rules about masking. And then realize that for the deaf community who are coming to our clinics for services, they can wear a cloth mask, not a problem. They can wear a paper mask. And everyone around them needs a transparent mask. And that caused us to actually take a different look at how do we supply masks, and what are the rules about who needs them and who should be wearing them. And, you know, until we had that experience, that was a missing element. And, you know, that's essentially the sort of thing that today is all about. Help us find those extra elements that allow us to be better providers, to be better members of society, better educators. Brad, you had something you wanted to say. Can you speak?
Yeah, this thinking back to when COVID started back in March, and the idea, excuse me, and the idea that we were going to have to start working from home and not be in the office and all that stuff. I think the two areas that I struggled with right after it started, and sometimes I still do a little bit, is the socialization part of it, and then also dealing with anxiety in different ways. I have anxiety to begin with in certain ways, and it triggered it to make it even worse at times. I figured out ways to manage it since then, and figured out ways. It took me to figure out ways to do the socialization piece, even though we do spend a lot of time on Zoom and doing work on the computer. It's not always the same as doing it face to face or social distancing. So, and I don't feel like I'm alone in that aspect, but those are just two areas that I felt like I really had to work on. And it's gotten better over the last couple of months, and hopefully we'll be done with this in the next who knows how long, and then we can get back to some sort of normalcy.
I think many of us share some of those same feelings. I hardly wait to get back. There is a question, I guess it's a general question for the panelists. What is one thing that you would like students in training, training to be healthcare providers, to know about people with disabilities? If you could wave that flag and have those students understand, what is the one thing you would like them to understand? Or, you know what? Don't limit it to one. If you got more than one, I'm not going to force you to pick.
This is Stephanie. I've got a couple of different things. One is for the students to remember that no matter what specialty you go into, you will have patients with autism or other disabilities. And please, as you are doing today, take the time to learn from individuals and families on how to best support them in the healthcare setting across the lifespan, not just when they're younger, when they become adults too. Another one is to remember, so I go to all of Matthew's appointments with them. However, I'm not the patient. A few years back, we had an appointment with neurology, and the doctor looked and spoke directly to Matthew, even though I was on the side asking the questions. Well, in that moment in my head, I had, hey, I'm the mom, talk to me. But after I had time to reflect, I was very happy that that doctor treated and respected Matthew as the adult that he is, and spoke to him directly versus talking to mom. So it's kind of hard when you start to feel as a mom that's done this care for so long, all of a sudden you feel insignificant. And so it's like, oh, wait a minute. But no, it's a good thing. It's a very good thing. So I really want healthcare providers to remember those two things.
That both of those are pretty common statements that not everyone gets to experience. But I would absolutely support those. Does anyone else have suggestions?
I want to add just a little bit to what Stephanie said. And one of the things that I would make sure that students know is, please think that if I'm coming to the doctor or whoever's coming, if I bring somebody to support me, please deem me competent to answer the questions. I get it at times when I've had people go with me in the past, and the doctor will talk to the person in the room. And one of the things that I've done to resolve that issue is that for the longest time now, I don't know when I started, but I go to all my appointments myself. And unless I want somebody to come to at least know what's going on, people that are important in my life or people that work with me on a daily basis, I'll ask them to come with me, but then I will either ask them if they want to come into the appointment with me, or sometimes they'll even just stay in the waiting room unless I need them to come in. So I just want to, I know it sounds pretty normal, but it doesn't always happen that way.
It's a very challenging social interaction because the natural thing is to respond to the person who's responding to you, even though that person is actually just an intermediary. And I'm certain that this is not just something that the people who've spoken experience. And I do want to point out, although that question was directed as, what would you like a student in training to know? I think this is important for other providers and for everyone else, including the faculty who may be teaching students. I think this is an important element in that personal independence and personal autonomy. Does anyone else want to add a sage wisdom for our audience?
I have a comment. This is Chris. you know, I want to echo what everyone else has said with that statement, and also people with a disability, you know, everything is interconnected and everything is related, you know, depending on all of the different disabilities, everything overlaps. And so, you know, I think it's important to keep in your mind, you know, as a student, you know, throughout your education and the system, to figure out, you know, how to really, you know, be empowered and empower the people you work with. And also empower yourself, you know, ask the questions. If you're not sure, you know, try to reflect and figure out, you know, what is a different way can I develop, you know, better skills? What, in what ways can, you know, I work with different people depending on, you know, their disability or what they're experiencing. And so I would just really want to thank the students, first of all, really just for putting in all the hard work. And also, you know, the students now, they have different minors and focuses that they work on as well. And just really just continue to attend events in the community, watch people's behavior, and just kind of become observant. And if it's something that you don't really, you know, understand, maybe look more into that and see, you know, how you can gain more knowledge in that area.
This is Stephanie, and I would say don't judge a person by their diagnosis and their med list. Those are huge. There are so many times that I would disclose my diagnosis and then my 6-med cocktail that helps me stay stable. And once that was out there, it was pretty much my mental health was addressed and not my physical concerns. And life expectancy for people with mental illness is 10 to 20 years less. And it's not because of suicide, like so many people would assume. It's comorbidity issues. It's people not receiving screenings, not receiving any kind of procedures that are routine procedures, because people just will chalk it up to their mental illness and ignore physical needs. And so many times people just shut off disclosing their diagnosis because of that. And then we all know what happens if you ignore the mental health component of it. And so it's really a fine line to walk between focusing on the mental health part and the physical health part. But it really is important to not judge someone just based on their diagnosis. I've had this happen to me so many times, and it's terrifying to disclose that. Even though I've had over 5 years of clinical stability, you know, people still look at people with mental illness as something that's not going to get better. And I think people also sell people with mental illness short. You know, we don't see recovery, or I like to refer to, instead of recovery, of mental health remission, because I do know that it could come back at any time, but remission is possible. And so not selling people short just because of a diagnosis, and not encouraging healthy lifestyle choices because you just assume they're not going to get any better. Why even spend the time worrying about it? I think those are really huge issues.
Stephanie, you may not be following the chat, but in the background, people are applauding your statements. And generally speaking, I think that's true for all of our panelists. I think the points that you raise are all current, really important, and often under the radar kind of things. And it often takes a few mistakes on the part of the provider to recognize that there's a better way to do things. Hearing this up front is probably really helpful. And you're right, once a person is labeled with a disability of any sort, very often that becomes the primary diagnosis, irrespective of what actually is important in that person's life at that time. There was something I wanted to address. Let me back up just a bit. We'll skip forward through a couple of questions. Some of those questions that we're not going to get a chance to answer probably in the next few minutes may reappear again in our 2:30 session. But I did want to point out that once the person is placed into this diagnostic category and they don't feel that they're actually receiving the services that they need, a natural response is to stop looking. And that then develops into this chronic comorbidity challenge, which, you know, if you're not receiving services because you don't feel you're being heard, that is a significant problem. Another element that is somewhere here in the questions is the issue of translation, not necessarily from the patient to the provider, but from the provider to the patient. And, you know, there's a lot of medical jargon, there's a lot of years of training, and very often the jargon does serve a very important point, and is important when providing care. You get just the right word. Unfortunately, that just the right word sometimes is not something easily understood by the patient. I make a point of speaking to my students, telling them that they need to be able to code switch. They need to be able to speak patient language and professional language, and they need to know when to do both of those things. And one of the things that they need to look for is confusion or understanding, lack of understanding on the part of the patient. If you see that, you can't just continue speaking. You need to ask, does this make sense? Let me write it down for you. All of those additional facilitating kind of activities. And I think that if a student goes into a setting where they recognize this, where they can practice it in a simulation environment, where they can have feedback about that aspect of their performance, they'll be better providers. And from my viewpoint, as a parent in this, who's been in this sort of situation, if you are the person who is recognizing that the patient is not understanding, speak up. You know, there's obviously some limitations for that. But I think that establishing that larger view, that communication is a two-way street and it needs to be respected. I'll get off that particular soapbox, sorry. Does anyone else have anything they'd like to add? We have another 5 minutes in this session.
One of a question that was presented before was how to be better disability advocates. And I think it's extremely important not only to advocate with the family, to advocate for themselves, but help them understand the importance of advocating, not just in the medical environment, but outside of that as well, when they're looking for supports and services throughout. And when they go and talk to legislators and whatnot, the power of their personal story is unimaginable. It's really important. And that's who they want to hear from. Legislators are going to be more apt to listen when they hear a personal story than necessarily from providers sharing secondhand information sometimes.
Well, there's enough going on in the chat that I don't even know where to start.
Ryan or Christine, you can help Jeff if you'd like.
Yeah, please. If anyone.
Jeff, have we talked about how COVID-19 has impacted everyone?
We did speak about that. There is a comment, it would be wonderful to provide a visual aid or chart, something a patient can refer to if they don't understand. Please slow down, please write down, can you repeat? That probably is not something that is commonly available in a clinic, but that Marian, our speech language pathologist, who is commenting in the chat as well, and I can talk about that, that would be a fantastic opportunity for a student project, is to develop and provide those kind of communication aids across campus. Marion's a new faculty member. I don't want to overburden her.
Do you want me to comment or not? I'm not sure if that's appropriate.
No, feel free.
Okay.
My job is to make people know that there are opportunities available out there.
Yeah, so let me get where you can see me. So yeah, those are terrific ideas. Those kinds of tools are absolutely already available and out there from the different, venues. The one comment I would make about that is that it is absolutely not enough to develop a standard kind of alternative communication device, such as pictures or drawings or single words, because different individuals have really different communication strengths and limitations. And so it's not enough to just hand a medical staff person a communication book, for instance. We need to understand what that individual patient in our setting has as their needs for communication. So I'm really happy. I've been posting in the chat. I'm thrilled about this topic. I've been in this field working on communication and communication differences for a long time. And so I'd be really happy to talk to anyone further about that. But we need to go beyond the step of just putting something in the room.
I think that's an important thing to say. If the communication aid is not in the room, it's not available. If it's in the room, that doesn't mean your job's done.
It's completely not done. And there has to be training of staff and an awareness of what that individual's needs are.
I see a dissertation project here.
I already did one of those. I just finished that. I just finished 5 years of PhD.
For a student, come on.
Okay. I'm still in student mode, I guess. I'm getting scared. You're scaring me. But yeah, so anyone who wants to talk about that, I'd be thrilled to do so.
Thank you.
If I can add to that, Jeff, I just wanted to thank everybody. I'm a physician provider in geriatrics, and we see a lot of disability when it comes to stroke patients, when it comes to dementia, where they have cognitive impairments. And what you bring up really helps highlight things that we need to do as providers, but also what we have to teach to our students. We have interprofessional clinics. We have occupational therapy students coming through, dietetic students, medical students, pharmacy students. And it's great to teach them these tools that you're giving us. So thank you for sharing really personal thoughts and professional thoughts that can help us in the whole healthcare system as a whole. So thank you.
Thank you, Shelley.
Really happy to help you with that.
All right, we're just about to close out this portion of the session. Our chat will be downloaded, compiled, and distributed in the symposium notes later after the symposium ends. We'll have a break from 9:20 to 9:30, and after which we'll begin with some perspectives from our providers and others. So please join me in thanking our panelists for sharing their insights. You're welcome to come back, to stick around, obviously, but also to come back about 2:30 for the general Q&A. If there are questions that are directed to a specific person over the course of the day when that person's not actually available, I'll make sure that the question is actually sent to that person and a dialogue developed. Thank you very much. Feel free to pop in and out over the course of the day, or ideally stick around. I'm not sure how we're doing the break. Are we just going to mute and go off and do things? Kimberly, you want to speak to that?
Well, during the break, people are welcome to leave and come back. We, those of us who stay on can chat until 9:30. I think this is, an open time to do whatever you need to do or to connect with each other. So.
And I'll remind people to be thoughtful about muting mics and videos while they're wandering around.
Just want to say thank you so much to the panelists, and we will be on break now until 9:30. Please return and join us as we continue through the day.
Thank you, folks.